Right. Good afternoon, everyone. Welcome to the afternoon sessions and what's been a really great day today. I'd like to congratulate Adam and Louise and the team for putting together an amazing program, and hopefully we'll be seeing this meeting as a regular part of the ID and transplant community schedule for years to come. So great stuff. We have got an excellent session after lunch. Thanks for hanging around. I'll be chairing it, and also I've been helicoptered in at the last moment to give a talk as well. And obviously, given I wasn't the first choice, you can imagine the quality of that talk will be diminished, but there you go. On the other hand, we have some other fantastic speakers that I'll introduce now. So first up, we have Dr. Benjamin Tay. So Ben's from the Peter MacCallum Cancer Centre in Melbourne. He's an associate professor of infectious diseases and a clinical researcher at the National Centre for Infections and Cancer. His interests include translational immune profiling, clinical studies of infection risk with new cancer therapies, and vaccination in cancer patients. And he's going to talk about vaccination in cellular therapy patients. Thanks very much, Ben.
Thanks, Crispin, for the warm welcome, and also thanks to the organizers for the invitation to speak today. All right. So a topic that's one of my favorite topics. So I thought today I'll talk to us about vaccinations in cellular therapy patients, but obviously it's a huge topic to cover. And I might just touch on areas that I think are interesting, where the data is and what the evidence gaps are in this field. So these are my disclosures, and just to state that the presentation reflects my personal views and not of any committee that I might be on. This is the overview, a quick introduction. I'm going to speak about what data is there to help us optimize our current vaccination schedules, and in particular for CAR T-cell, what data is there for revaccination as well. And then to finish off, just to talk on new vaccines and approaches to cellular therapies patients, in particular for the infections that you see there. So this audience, I think, needs no, this topic needs no introduction to the patient, to this audience, that certainly we do know that patients undergoing treatment with cellular therapies are increased risk for morbidity, mortality from vaccine-preventable infections. But it comes with its challenges, because this is the same group of patients that will have impaired response to vaccines. Duration of immunity is often shorter, and live vaccines are contraindicated. But very fortunately, we don't have that many live vaccines in practice. So, why vaccinate? Because we do have very good data that certainly for the diseases that's listed there, that vaccinations in this group of patients reduces the incidence, morbidity, and mortality for high-risk patients. So I'll just launch on to talk about CAR T-cell. I think I won't belabor CAR T-cell. I think we've heard a lot about it in the last couple of years. And certainly, unfortunately, the data with regards to vaccination in this patient group lags behind, how exciting the technology is. And certainly, the early data that we have are predominantly from sero surveys that have been conducted now, with limitations of these surveys because they are often small. They are from very sort of non-longitudinal, but certainly it gives us, perhaps some early clues that certainly there's a difference between retention of immunity between patients who have received CD19 targeted CAR T-cell versus BCMA CAR T-cell, where there's higher retention of seropositivity in CD19 CAR T-cell patients. And when we sort of drill down to look at pathogen-specific retention of antibodies, it's low for diseases like strep pneumo, Haemophilus influenza Hep B, around moderate for measles, mumps, and rubella, but high for more, if you like, classic infections, tetanus, polio, and varicella. Very small studies looking at vaccine responses in influenza, with influenza vaccination in this patient group, which shows that, unfortunately, seroconversion remains low. But this is not surprising, because the endpoint of these studies are immunogenicity, predominantly humoral, which in a B-cell depleted patient cohort. So I wanted to present some data that we've actually performed at Peter Mac, and this is work from a wonderful PhD student, Gemma Reynolds, who was able to show that certainly in a longitudinal cohort of patients, around 20, again, not huge numbers, but we're certainly able to show that post when you look at it before 3 months and 6 months post-CAR T cell, there's high retention of MMR, Hib, and tetanus-related immunity, and it remains high actually up to 6 months. And these are patients who are not receiving IVIG. So I think that's the important difference between this study and other studies. But unfortunately, it's not the case for pneumococcal. So pneumococcal retention of immunity remains low. We do see that certainly patients, when we look at patients who are receiving IVIG, then certainly, not surprisingly, there's a top-up effect and there's high seroprotective rates for pneumococcal with IVIG replacement. What about, CAR T vaccination schedules? What you see now in the international literature is basically all opinion-based from different experts around the field. What I present here on the screen is a particular one from Josh Hill and Susan Seo from the US, who from 2 cancer centers who deal with a lot of CAR T cell patients. And this is their proposed vaccination schedule. Inactivated vaccines, safe, you can commence them about following 3 months following CAR T, but they do add a component of ensuring immune recovery, and there are different criteria for defining what constitutes immune recovery. And they do recommend testing response to vaccination, but this is, of course, a bit challenging in the Australian context. So what do my center do? So we actually, because of the lack of evidence and we're trying to build that, we certainly for now conservatively use the same schedule as our stem cell transplant, accepting that this might be an overcall. But I think we certainly need to build better evidence to refine our practice. Speaking of which, I think people have forgotten about autologous stem cell transplant somewhat. It is still the large bulk of our stem cell transplant program. However, as you might know, with the current vaccination schedule, revaccination schedule, it's recommended to be the same as our allogeneic transplant cohort, but we do know that the tempo of immune recovery is very different. So can we actually improve our recommendations with autologous stem cell transplant? And this is work done by a different PhD student who's also equally fantastic, Victoria Hall, who looked at basically, again, retention of seropositivity and response to vaccination in the early days after autologous stem cell transplant. And what we see, very similar to CAR T cell, strep pneumo, I think is a component of the fact that we're not as good at vaccinating patients early for strep pneumo in this patient cohort. So seropositivity rates are low, but again, high for tetanus, Hib, measles, mumps, rubella, and varicella. And again, remains very stable over the first 6 months. And when we look at the first dose of vaccination, we have quite good seroconversion rates. Again, very different population from CAR T cell, that we can achieve a seroprotective rate of 55% for strep pneumo after 1 dose, but very high with tetanus and Hib after just 1 dose, suggesting that we may not need as many doses in our autologous transplant group, because currently they're recommended, for example, to have 3 doses of Hib, 3 doses of tetanus. So still early days. I don't think it's enough for us to say that we can, completely overhaul the schedule, but I think tantalizing evidence that we can do better and potentially reduce the number of vaccines and therefore needle burden in our autologous stem cell transplant cohort. No vaccine talk is complete without COVID, so I'll whiz through this, but it's interesting to see that there are certainly differential serological responses depending on the type of cellular therapy that the patient's receiving, the highest being autologous. Some allogeneic is relatively high. I think what you see there is a reflection of the fact that in these studies, patients were vaccinated later post-allogeneic stem cell transplant, but the lowest is the CAR T cell cohort. However, it's not all bad news. I think that is humoral responses. And as I've touched on with CAR T cell, you have B cell depletion. So not surprisingly, you see lower responses when you try to measure it. But when we looked at their T cell responses, actually T cell responses to the COVID vaccine in this patient cohort were actually very robust and almost comparable to a healthy cohort of patients. So, and we do know that T cell responses in COVID tend to correlate better with protection against severe disease. You can see, roughly the rates are 15 to 20% higher response rates to the vaccine compared to human responses. And in seronegative patients, even 40 to 50% actually will have positive cellular responses despite having a negative humoral response. So what about timing these vaccines? I think, there's always, if you like, a legacy recommendation that we have to wait 6 months for more seasonal type vaccines like influenza, and then by extension, then COVID followed the same. But there's actually good data to suggest that we can actually vaccinate quite safely and effectively earlier. So this is a nice study from the BMT group in the US, where they showed that timing did not significantly impact responses, where if you vaccinate earlier than 4 months post, in this case, allo transplant, it was not inferior to late vaccination. And I put a star there because there's some caveats around it. Don't have time to go into it in great detail, but certainly happy to discuss it after my talk. So the majority of patients were on who were vaccinated were still vaccinated while on immunosuppression, and very similar safety profile. They have a bigger study that that's in preprint, where they've reported very similar findings for autologous and similar findings for CAR T-cell patients as well. What about pre-transplant vaccination? Well, the same study plus a different study certainly showed that patients who completed 2 doses 3 months prior to their allo transplant certainly had higher antibodies that have been sort of bridged post-transplant. And certainly the higher RBD levels then responded better to vaccinations post-transplant. So suggestions that we could in patients making sure that they should be up to date with their vaccines heading into a transplant. So just touching on new approaches to vaccination, I'll start on influenza vaccination first, because it was one of our major respiratory viruses, of course, before COVID took all the attention from it. So this is part of what I'll cover. So we do know that in this patient cohort, we want new and better vaccine approaches and vaccine formulations, and certainly using single dose of either the high dose or adjuvanted vaccine versus standard dose vaccines, that we see higher rates of immunogenicity, particularly seroprotection for H3N2, numerically higher rate of seroconversion, but not statistically significant. But also the downside is higher rates of local reaction. So smaller randomized trials providing tantalizing evidence, which led a lot of the similar investigations to go on to look at using 2 doses of high-dose vaccines versus 2 doses of standard dose vaccines. And these are studies in the allo transplant population, the first one in adults and the second one in pediatrics, which confirms again a higher level of immunogenicity for certain strains, not all, so H3N2 and B Victoria, which then remained higher at the end of their randomized trial. And certainly there are some factors associated with better response, the use of high-dose vaccine, a longer time since transplant, higher CD4 counts, CD19 cell counts were also associated, but balancing that with a higher rate of quite manageable local adverse events, usually injection site pain. The similar findings in their pediatric allo transplant study. We, a few years ago, looked at more just a prime boosting type schedule, looking at high dose, standard dose versus standard dose. But in the autologous stem cell cohort, and we found really high rates of seroprotection and seroconversion with no difference between the arms, and rates remained high at 6 months. And this is in a setting of the fact that the majority of autologous transplant patients are myeloma patients who are on immunomodulatory drugs like Revlimid, which tends to be associated with better immune responses as well. But in this study, we also, patients were vaccinated as early as 1 month post-transplant, suggesting that you can actually vaccinate for seasonal vaccines much earlier than we used to think, like I said, much earlier than 6 months. So to summarize, in terms of the influenza field, I think, enhanced influenza vaccines are certainly more immunogenic than standard dose vaccines. However, it's the challenge are always with immunogenicity studies in this field is whether this translates to better clinical efficacy. There's certainly more data for the high dose formulation, but this is not available under our national immunization program, whereas we have the adjuvant dose vaccine. More local AEs I've mentioned. So the vaccine schedules, just to emphasize that, I think, immune responses are good early post autologous transplant and allo transplants, so we can certainly vaccinate earlier. What about the recombinant zoster vaccine? That's the other vaccine that's been, in the news in the last year. So certainly, with the recombinant zoster vaccine, this is the pivotal trial done by the company where the vaccine efficacy is 68% in the autologous transplant group. And interestingly, there's a better risk reduction in patients who receive shorter duration of antiviral prophylaxis. But not surprisingly, in this cohort of patients, immune response declines with time, and further follow-up is ongoing, but it looks as though it starts declining around 2 years. The AEs are as listed there. The challenge has been that the trials were done it's slightly in reverse for recombinant zoster vaccine. So we have more data in autologous and less data in allo transplant, which is normally the other way around. But so we have observational studies related to the use of recombinant zoster vaccine or Shingrix in allo transplant patients, where 2 doses have been given quite late post-transplant relative to the auto group, where the rate of zoster reactivation was 3% compared to a historical cohort of 12%. Immunogenicity wasn't great at around 18%. So I think in this cohort of patients, there's still work to be done to help define what is the best timing for this vaccine in the allo transplant patients. So that's that in summary form. And I'd like to sort of then move on. In the interest of time, I'll just try to whiz through them. So the next big area, of course, is the pneumococcal vaccines, because there's lots of exciting developments in the formulations of pneumococcal vaccines coming through the pipeline. So this was a recent clinical trial which looked at the use of an additional PCV13, so pneumococcal conjugate 13 dose, where we currently, as a standard, we already give 3, followed by a dose of the polysaccharide vaccine. So this trial evaluated slotting in an additional conjugate vaccine into the schedule. But as you can see, that the headline rates are very similar overall response. So no additional benefit. There's a temporary benefit, of course, when you give an additional dose, but overall, when you look at it at the endpoint, similar overall response. PCV15, which is not on our NIP, but certainly available on the private market. And this was a study looking at the allo transplant group, and it was in comparison to PCV13, very similar study to the previous studies led by Catherine Cordonnier, 3 doses of PCV followed by PPV23 or PCV in people with graft versus host disease. Headline result, comparable titers for the shared serotypes. Of course, for the ones that are missing from PCV13, it is higher, and that's not surprising. However, when you boost PCV13 with PPV23, actually, they all level out. The downside, of course, with PCV15 is that you have higher injection site AEs, but very similar rates of graft versus host disease. What about PCV20, which is the next version coming out? Unfortunately, no data in immune-compromised patients, but certainly in non-immune-compromised general, more older age group patients show that very similar findings to previous, that for the shared serotypes, non-inferior except for 1, and then, of course, higher GNTs for the serotypes that are not included in the PCV13. And just to touch on before I start wrapping up, RSV vaccines, again, very topical, but also, unfortunately, again, no data in our immune-compromised or in cellular therapies, patients receiving cellular therapies. A very effective vaccine in the general cohort of patients in anyone 60 and above, a single dose, and you can see there are different companies making different versions from all involving the pre-fusion F protein and with or without an adjuvant, but very high vaccine efficacy between 83 to 86%, with slightly different definitions with each study of what they consider to be the primary endpoint, but quite similar, but very high rates of vaccine efficacy, and certainly for severe lower respiratory tract infection with RSV, again, very high, and looks as though the data certainly supports it does trend down, but still relatively good into the second season. So it suggests that we don't, for RSV vaccines, at least in the general population, it's quite unlikely that we'll need to dose this every year. But exciting developments in RSV, and hopefully there'll be more data coming out in places like the US where it's being used in our transplant patients as well. So I think just to wrap up, I think in summary, there are new formulations of PCV, but I think its role following cellular therapies is to be defined, whether it replaces PCV13 completely, and if it does, whether you still need the polysaccharide vaccine after that. And with RSV vaccines, there's unfortunately no data. So, but we do know it is safe because they're not live vaccines, and certainly, but we would expect that the vaccine efficacy in this patient group to be lower. And I think it's still an open question about the timing of vaccination, whether you vaccinate pre the cellular therapy or post that. These are, I think, areas that I think are, for future research, and certainly, we are working on some or hopefully all of these questions, and we of course invite collaboration at our center. And these are, I think we need studies to define, the post-CAR T vaccine schedule, to hopefully refine a little bit better our autologous transplant vaccine schedule, even though this has gone on for a very long time. Timing of our the recombinant zoster vaccine for allo, and immunogenicity of the new vaccine formulations. And I think, we require new vaccine approaches to certain things like influenza, because there's still a cohort of patients for which the vaccine response remains poor. And I still think it's very important because unfortunately we'll never get large scale vaccine efficacy studies in this patient group because you need thousands of patients, and it's all reliant on immunogenicity. And I think at the moment, the vast majority of immunogenicity is humoral, which is problematic in some patient cohorts in this group. So we do need new correlates of protection. I will invite questions, but I thought I'll just give a plug, since this is an audience interested in transplant ID, that we do want to improve our reporting of infection adverse events across all study types, across all immunocompromised patient groups. So this is an effort, an international multi-society effort across seven societies around the world, where we want hopefully a more consistent approach to how we report infections, so we can then compare across all our studies. I'm sure everyone's frustrated when you read studies with very different definitions of how they even classify infections. So this is a first attempt. It's by no means a final attempt, but just to publicize that it's now available. And I'll take questions.
Thanks, Ben. Thanks very much. Awesome talk. Look, we are quite a long way behind schedule, so there might not be time for questions. Although if you stick around, we might be able to ask you. There's a study I want to propose to you. I've got cash. It's good. So I feel like at the airport when they say your flight's been delayed because the inbound flight was delayed. Well, that's the situation I find myself in at the moment. But we're going to crack on. That was a fantastic talk, though. Heaps of content there. So an area where there's just so little data to inform anything, and the guidelines are all really vague.